Hello everyone, this is Dr. Ashley Utchison from the Academy of Online Radiology Education. I work at Baylor College of Medicine in Houston, Texas. This month, we have curated some interesting literature on breast imaging. In this study, authors sought to determine the relationship between the degree of breast edema on TT-weighted images and prognosis of breast cancer patients treated with neoadjuvant chemotherapy. Breast MRIs from 408 women treated with neoadjuvant chemotherapy obtained between January 2011 and December 2018 were retrospectively reviewed. Breast edema was scored 1 through 5, with 1 equaling no edema, 2 equaling peritumoral edema, 3 equaling prepectoral edema, 4 equaling subcutaneous edema suspicious for occult inflammatory breast cancer, and 5 equaling clinically evident inflammatory breast cancer. Differences in progression-free survival and overall survival between breast edema scores was determined using the log rank test. Statistically significant differences in progression-free survival were present between breast edema scores of 4 versus 1, 5 versus 1, 5 versus 2, and 5 versus 3. Overall survival rates were lower in breast edema scores of 4 and 5 compared to scores of 1 through 3. The authors concluded that prognosis of patients treated with neoadjuvant chemotherapy was related to a breast edema classification score. In this study, authors sought to determine the diagnostic performance of abbreviated screening MRI and to compare yearly screening outcomes between 3 consecutive years. Between September 2015 and August 2018, approximately 2,000 women underwent approximately 3,000 abbreviated MRI exams, which included T2-weighted and contrast-enhanced dynamic sequences. There were no statistically significant differences between consecutive years for cancer detection rate, sensitivity, specificity, positive predictive value for recall, positive predictive value for biopsy, abnormal interpretation rate, and interval cancer rate. All missed cancers were early-stage invasive disease without nodal involvement. Missed cancers were also statistically smaller than cancers detected on abbreviated screening MRI. The authors concluded that there are no significant differences in abbreviated MRI screening outcomes over 3 consecutive years. In this study, authors sought to compare performance indicators between first and second MRI screening rounds in the dense tissue and early breast neoplasm screening trial conducted between December 2011 and January 2016. This trial was associated with the Dutch population-based mammography screening program for women ages 50 through 75 years old. Enrolled women with dense breasts and a prior negative mammogram underwent an initial round of supplemental MRI screening. A second round of MRI screening was performed if women had a subsequent negative mammogram after their first MRI. Approximately 3,400 women underwent a second MRI. The false positive rate was 26.3 per 1,000 screening exams compared to 79.8 in the first round. The cancer detection rate for the second MRI was 5.8 per 1,000 screening exams compared to 16.5 in the first round. The positive predictive values for recall and biopsy were comparable between the 2 screening rounds. The authors concluded that lower cancer detection rates and false positive rates were likely due to availability of prior MRI exams and an overall smaller pool of prevalent cancers. In this study, authors sought to investigate the effects of shear-wave elastography image quality parameters on the diagnostic quality of calculating elasticity measurements to categorize breast lesions. From October 2017 to August 2018, 281 breast lesions that underwent shear-wave elastography and ultrasound-guided biopsy were retrospectively reviewed. 3 blinded radiologists rated the image quality of the shear-wave elastography exams as poor with a score of 0 or high, a score of 1, which included parameters like B mode, visualization of the lesion, presence of a near-field red pattern, field of view placement, and appearance of surrounding tissues. Shear-wave elastography images were considered high quality if near-field red pattern and B-mode visualization received scores of 1. When compared to low-quality shear-wave elastography images, high-quality images had significantly greater area under the curve values. The authors concluded that the use of shear-wave elastography quality parameters to generate high-quality exams can improve distinction between benign and malignant breast lesions. In this study, authors sought to examine the relationship between background parenchymal uptake, otherwise known as BPU, on molecular breast imaging, and risk of breast cancer. Nearly 3,000 women without a history of breast cancer who underwent molecular breast imaging between 2004 and 2015 comprised the retrospective cohort. Radiologists were blinded to patients' future breast cancer diagnoses and graded BPU on molecular breast imaging as low or elevated. Within the cohort, 144 women were diagnosed with breast cancer after a median follow-up time of 7.3 years. Overall, increased breast cancer risk was associated with elevated BPU, but was only significant in postmenopausal women. The 5-year absolute risk for breast cancer in women with elevated BPU was 4.3% compared to 2.5% in women with low BPU. In postmenopausal women with dense breasts, the 5-year absolute risk for breast cancer increased to 8.1%. The authors concluded that elevated BPU is associated with an increased risk of breast cancer, particularly in postmenopausal women with dense breasts. In this study, authors sought to examine the relationship between digital mammography and sustained increased detection of DCIS, as well as upgrade rates of DCIS to invasive cancer. 484 cases of mammographic calcifications diagnosed as DCIS obtained between 2001 and 2014 were included in this retrospective study. During this time period, the institution used both film screen mammography and digital mammography, with a full transition to digital mammography in 2010. Of the included DCIS cases, digital mammography had a higher detection rate compared to film screen mammography, with a double detection rate for high-grade DCIS. These rates persisted after the prevalent peak of digital mammography detected DCIS in 2008. Upgrade rates of DCIS to invasive cancer were not statistically different between digital and film screen mammography, and 71% of upgraded invasive cancers were initially high-grade DCIS. The authors concluded that digital mammography demonstrated double detection rates compared to film screen mammography for DCIS detection, which were sustained after the prevalent peak. Additionally, authors determined that upgrade rates to invasive cancer were similar for film screen and digital mammography. In this study, authors sought to examine the utility of diffusion-weighted imaging for targeting lesions in MRI-guided breast biopsies. 87 MRI-guided breast biopsies performed between March 2019 and June 2020 were included in this study. A preliminary diffusion-weighted sequence was obtained to determine lesion visualization, and 64 lesions were seen on diffusion-weighted imaging. Mean size of the mass and non-mass lesions were 10.7 millimeters and 33.9 millimeters, respectively. The biopsy needle was seen on diffusion-weighted imaging in 96.9% of cases. The biopsy site marker was confirmed with T1 imaging per standard protocol, but was identified in 95.5% of cases on diffusion-weighted imaging. The authors concluded that diffusion-weighted imaging is an effective and reliable sequence for targeting non-mass and mass lesions of at least 5 millimeters when lesions are visualized on pre-procedure diffusion-weighted imaging. Diffusion-weighted imaging also provides reliable detection of the needle device and biopsy site marker and may provide a more cost-effective alternative to contrast-enhanced MRI-guided breast biopsies. In this study, authors sought to determine the diagnostic efficacy of contrast-enhanced ultrasound in diagnosing malignant non-mass breast lesions. Approximately 100 patients with non-mass breast lesions seen on conventional ultrasound were included in the study. Enhancement patterns on contrast-enhanced ultrasound were compared between benign and malignant non-mass breast lesions. Additionally, the authors compared the diagnostic performance of BI-RADS ultrasound, contrast-enhanced ultrasound, and combined BI-RADS ultrasound with contrast-enhanced ultrasound. Diagnostic indicators on contrast-enhanced ultrasound included radial or penetrating vessels, enhancement area, and enhancement degree. Sensitivities for BI-RADS ultrasound, contrast-enhanced ultrasound, and combined BI-RADS ultrasound with contrast-enhanced ultrasound were 100, 80.4, and 94.6% respectively. Specificities for BI-RADS ultrasound, contrast-enhanced ultrasound, and combined BI-RADS ultrasound with contrast-enhanced ultrasound were 30.2, 74.6, and 77.8% respectively. The authors concluded that contrast-enhanced ultrasound demonstrated the highest specificity but lowest sensitivity in the diagnosis of malignant non-mass breast lesions. Combined BI-RADS ultrasound with contrast-enhanced ultrasound provides the highest sensitivity and specificity for diagnosing malignant non-mass breast lesions. For more details, you can read our blog where you can find links to the original publications. Please feel free to share your thoughts and questions with us on the Breast Imaging Forum, and we'll see you next month.